All right, so leading up into lunch, we're going to go over some questions.
The most important thing is I wish someone would hug me for 2 hours. That would be nice. Still hoping, Bob. Still hoping, Bob.
That's funny. So we got Dr. Anthony coming up here. So how about we start with Dr. Trikolinos? Question is, what can a gastroenterologist do to diagnose a neuroendocrine neoplasm sooner or more accurately?
So we actually had this discussion in private about an hour ago. Your gastroenterologists are usually pretty adept at figuring out what's very easy and very simple. So a common cause for diarrhea, inflammation, or anything that is very easy to spot, they know about it. Everybody develops this sense that tells them that a common thing is happening. The problem is that a lot of times gastroenterologists will just ignore that sixth sense that something is going on, and because the tests are negative, they'll start ascribing all the symptoms to something else. So whenever a gastroenterologist, that's what we tell gastroenterologists in general, you shouldn't be looking for neuroendocrine tumors, day in, day out. Most people have diarrhea. I've had diarrhea. It's not that uncommon, but when things just don't fall into a very simple and quick category, start thinking about the neuroendocrine neoplasm potential, because that's the problem with most of our patients. They didn't just get ignored, they got ignored for years. They kept going with the same problems, and the gastroenterologist kept saying, try a little bit of this, try a little bit of that, try a little bit of the Imodium, and at some point it became a process where they actually started getting angry at the patients and saying, it's all in your head, or you shouldn't eat all that spicy food, I bet you had some food. When you reach that point, when something doesn't make sense, just start considering unusual causes. And most of the times, it's not going to be a neuroendocrine neoplasm. And I think it's catching on. It's the same thing in our tumor board. When we discuss somebody, and we're like, that just doesn't look like what we usually see, then it's time to sit down and consider something completely different. So advice, if it's been more than 3 or 4 times, three or more treatments that you tried unsuccessfully and your tests are negative, you have to start looking for zebras. I mean, it's so obvious.
Yeah, and the old adage is, when you hear hoofbeats, think horses. So that's what the way it would teach us in medical school. But with our group, we think zebras. So we have to switch up that moniker. So I will add just briefly for the gastroenterology workup, sometimes I have utilized a double balloon enteroscopy. So that is a procedure where the gastroenterologist can examine the small bowel, right? So a colonoscopy only goes up to around the terminal ileum, and some of these tumors will be hiding right behind this valve called the ileocecal valve. So this double balloon enteroscopy has transformed the way that the gastroenterologist can examine the small bowel. So we can talk more about that offline. Okay, so next up, question for Dr. Anthony. So the question is, should I stop eating chocolate?
Only if the chocolate is eating you.
He is a big chocolate connoisseur, so I'm not surprised.
So in all seriousness,
Stop eating cheap chocolate, I think.
Yeah, that's a good point, Eric. So really, it's what's in chocolate? Theobromine. It's in caffeine. So these are agents in the diet that can provoke illicit symptoms. So if it's eliciting symptoms, then don't do it. So that's sort of what it's all about. But I don't know if it's dose related or not.
But I think that's an important thing. There are a lot of myths in neuroendocrine, and I will say this right here. There are myths that are just not true, and some of those things can. And the reason they were brought up is because they can be things to explore that might make you not feel well, but none of the things actually ever really kill anyone. So you cannot, death by chocolate is just a marketing ploy. It's not a real thing for us. So if you try it and it works okay, then by all means, eat it. If it makes you feel sick, then don't, right? It's like that old adage, Doc, I keep banging my head against the wall. Doc says, stop banging your head against the wall, right? I mean, it's the same thing. So it's not that it's toxic, it's not that it's going to kill you, it's not that it's going to accelerate the cancer. It just means that it may make you feel a little worse, right? So for example, I don't exercise because I think exercise is very dangerous.
One.
I know, that's right. Risk benefit.
Yeah. All right. So eat chocolate if it makes you feel good. If it doesn't, don't eat it. So next question for Dr. Liu. Oh, he's going to like this one. How important is it to have your tumor removed by a neuroendocrine surgeon? And if you already see a specialist for NET or neck, would any good surgeon be able to be as successful?
Well, I mean, that's actually a little bit more nuanced, because the answer is always no, right? I mean, you should always go see a neuroendocrine surgeon, right? And I mean, I just feel very strongly about that. However, if you are sick, if you have a problem and you can't get, you need help right away, then you need something. My only challenge is that after they kind of get you out of the the burning forest, is now someone needs to carry you back to the village, right? And so sometimes I have to go back and do the operation again, which is fine. It's not that you can't do that. Maybe you wait a year or 2 or 3 before you go back. But, or sometimes it's not done quite correctly and I got to go back right away. And so and I'm not perfect by any means. I want to really confess that. I'm not perfect by any means. But if you can do it better up front, it's just better, period.
Lou. So next question for Dr. Chauhan. How long can a patient be on lanreotide, and are there any long-term side effects?
Thank you, Dr. Starr. So lanreotide is the relatively newer entrant between the 2 available products in the US for long-acting SSA or monthly. Dr. Anthony has been using this class of drug, the somatostatin analogs, for several years before that. There was a short-acting version. So we have considerable amount of safety, long-term safety data with use of this class of drug in general. And we haven't really seen long-term detrimental side effects which will, make us stop the drug for concerns of side effects. Now, having said that, no drug is without any side effects. If you look at the back label of Tylenol, it might scare you. So things that can happen with somatostatin analogs could be steatorrhea, pancreatic insufficiency. Some people have generalized muscular aches and joint aches. Majority of patients would not have significant side effects. In fact, it is actually causes a drastic improvement in quality of life. They feel better, more energetic, symptoms dissipate, and things like that. So a short answer, at least based on what I've read and my experience, as long as patients are receiving benefit from SSAs, be it lanreotide or the other product, they can continue on it as long as not giving them terrible side effects. Sometimes a patient might just get sick and tired of getting shots for 10 years and there's a lot of scar tissue and there's just no other way to go about it. So we have to kind of factor in all of those things, okay? There are also now other agents. For example, Zermelo is another agent which has been FDA approved for SSA refractory carcinoid syndrome diarrhea, right? So we have more tools in our toolbox. But this is a very safe medication and can be taken indefinitely as long as it's working and helping and benefiting patients.
Thank you, Dr. Chauhan. Yeah, when I see patients in clinic on SSAs, I try to counsel patients on the risk of gallstones, right? And typically that'll happen within like the first 2 years of being on it. So I think it's important to be on the lookout, if you start having pain on the right side, radiating to the back, or you have pain after eating and that, makes you feel nauseous or just sick. That's one that we counsel patients on, so just be aware of that. So the next...
Dr. Starr, I'd
please.
also like to mention hyperglycemia and hyperlipidemia. And all of us should be seeing our primary care doctor once a year, if not more. And these are some common things that we routinely check regardless. So please be on a lookout for elevated sugars. This can certainly not cause massive amount of hyperglycemia, but can push somebody who's teetering on the borderline diabetes. So those are the other couple of things.
I want to also give a shout out to our surgeons here. Do we have any surgeons? Oh, Eric. Eric, a shout out here. When you operate on a neuroendocrine tumor patient and you know they're going to be on somatostatin analogs, do you think about their gallbladder?
So what Dr. Anthony is saying, that one of the major side effects of being on the shot for a long time is actually gallbladder problems. I'm sure most of you don't have your gallbladders because you're on the shot. So when I do liver surgery, I can take out the gallbladder in about 7 minutes, maybe 8. And so it's much easier for me to remove the gallbladder at the time of a big surgery. But it's a little bit more nuanced than that. Actually, what I do is I think very hard about how hard it would be to actually go back and do another operation if they developed it. Because maybe 25, 30% of people develop real problems with their gallbladder and actually need surgery. And it's a problem, yeah, exactly. So I do think long and hard about it because there's a technical aspect to it. And I say that because I've had to go back in people who had a big whack and then didn't have their gallbladder out, and then I got to go back, but I can't do it with my little chopsticks anymore, right? So I have to make another big cut to go in and get it. So those are the kinds of things I have to think about, because I have to think, when I take care of you, I have to think about you now, I got to think about you in the past, I got to think about you in the future. And so
You're also thinking about what drugs are going to go on too.
Correct.
And
right.
complications of those drugs.
Correct.
That's the
exactly.
whole point of
That
this
is correct.
question.
He is correct, right. So we have to think about your whole journey.
A non-neuroendocrine surgeon might not be thinking about somatostatin analogs lifelong and the risk of gallstones.
Correct.
Take the gallbladder out. All right. So this is a question for Dr. El-Khouli. So will a gallium scan or a dotatate scan ever pick up something other than NETs?
Thank you. Thank you so much. That's a great question. Yes, of course, it does all the time. First of all, it's not only neuroendocrine tumor that is somatostatin analog avid or dotatate avid. There are other tumors that express somatostatin receptors, meningioma, for example. Some are benign, some are malignant. Inflammatory, like sarcoid. I had a case that I had to flip through because I was running out of time that showed you that has sarcoidosis with neuroendocrine tumor. And I had FDG and dotatate for that case that showed both of them. So there are a lot of other tumors, benign, malignant, so there are pitfalls. We know them. As radiologists, as nuclear radiologists, we know these tumors, we know how to read them, and we recognize them. Of course, yes, there are. And this is true not only for dotatate, this is true for all the radiopharmaceutical we deal with. Every radiopharmaceutical. There's nothing, when we say specific, it doesn't mean that there's nothing that only picks up in one specific, there's nothing like that in life, right? If I say that, don't believe me. Don't believe anyone who says that. So it has to have pitfalls, it has to have collaterals, it has to have other things. But we know them, recognize them, and we actually make use of them. So there are, like for example, there are research to use dotatate for meningioma and meningiosarcoma. And so, yeah, of course, yes. It's a beautiful question, and thank you for that question.
Can I add a little bit? So
Please.
This year, we, like 2 weeks back at NANETS, we presented a poster from Markey Cancer Center where we tested various other tumors for somatostatin receptors. So SSTR has been very well known, established biomarker in NETs, but it's not the only tumor where we see somatostatin receptors. We are all exploring small cell lung cancers, Merkel cells, paraphios express somatostatin receptors. So head and neck sometimes, certain indolent lymphomas. So whatever tumors have somatostatin receptors will also can technically be picked up on imaging which targets somatostatin receptors. So this is an evolving field. You might see more indications, or at least research in those aspects.
I'll keep in mind next time I present to you guys, I'll show you some of these. I have a lot of them.
Thank you. Great discussion there. So question for Dr. Trikolinos. If a patient had surgery to remove a small bowel primary neuroendocrine tumor, are there studies to determine if somatostatin analogs are beneficial to prevent metastasis?
I love it how you're asking me the surgical question.
Never ask the oncologist about surgery.
We learned that already.
So the short answer is we grappled with that question a lot. So for a lot of the cancers that we deal with, classic cancers like colon cancer, breast cancer, some form of treatment afterwards to prevent the tumor from coming back is warranted. Not for everybody, not all the time, but for neuroendocrine patients, it just hasn't worked so far. Whether you should be giving, in the absence of disease, treatment to prevent something from coming back, something that may not come back ever, is doubtful. Now, say that you knew the future, that you're good, and you know that a tumor problem will come back at 10 years or 15 years. Is this worth treating for 10 to 15 years with a monthly injection, all those expenses to prevent this from coming back, at 15 years? It's a bigger question because sometimes we don't treat patients at all. And then, most of the treatments that we have just delay the progression. So is this really worth it? Now, there's more to say in people who have some leftover disease. Should those people go ahead and get more surgery? And I will put a question mark there. Should you just observe this if it's not causing a lot of problems, it's not growing fast? So these are nuances that we just don't really know. A huge question is what to do after PRRT. You've treated your disease. PRRT can prolong that, that progression-free survival. People can be well for a while with disease that you can see. Should they remain on somatostatin analogs? That's an area of active, discussion, and we're actually working on that. That's a concept we're presenting soon. So.
Yeah, that's a highly debated topic of whether to continue somatostatin analog after PRRT. They did it on the study with no real good justification, which makes you question the intention. But thank you. And I'll plug one of our colleagues, Dr. Heloisa Soares, has a clinical trial not looking at, it's particularly in pancreatic neuroendocrine tumors, but looking at chemotherapy after surgery to see if it helps prevent these tumors from coming back. So this is the first study ever in neuroendocrine tumors to be, really studied the proper way. So we're excited to see if we can improve cure rates for pancreatic neuroendocrine tumors. So this is a question for Dr. Anthony. Necrosis is cellular death. Why is its presence in a pathology report a bad thing?
Why is it in a pathology report? What was the last of that question?
So if we see necrosis on the pathology report, why is that a bad thing?
Why is it a bad thing? Okay. So necrosis implies that the tumor is growing fast enough that it's outgrowing their blood supply. So the biology is a fast-growing tumor. When it applies to the pathology of neuroendocrine tumors, it's useful for bronchial carcinoids because pathologists, if they see necrosis on the original tumor, they will call it atypical. So it's a critical finding at the time of diagnosis. Now, part of what I do is I create necrosis. That's kind of what's keeping me in this business. I know I'm not a surgeon, I'm not a radiation biologist, all that, but I'm really, this case that I saw you today, that case, Robin Bullock, those spots on her liver underwent necrosis and her liver healed. And no, she didn't get a multivisceral organ transplant. Now, we did take her primary out. I mean, surgery's critical in surgery, but we don't have to do surgery on every, fine surgery on every cancer cell. I'm not saying that Robin's cured, but having worked with her for 5 years and she's off all medication, she's not on somatostatin analogs, she's not on mTOR inhibitors, she's not on anything for a year, and she's got a great quality of life. So I think the pharma industry is probably going to kill me. I think the surgeons are already put a bullet on my back.
I like just a quick addition. So necrosis on the prelim or the original diagnosis is not a good sign, as Dr. Manthony mentioned. It means that tumor is overgrowing its blood supply. But if we have a biopsy post-treatment, there you see a lot of tumor necrosis. That could be sometimes good sign. That means the tumors, the treatment's working. So I just want to make sure that we don't confuse. So what we meant necrosis, it's an original pre-treated sample.
That's important to clarify and hard to interpret. So I'm glad that question was brought up. So question for Dr. Liu. I'm opening up a can of worms here. So patient presents with stage 4, small bowel, well-differentiated neuroendocrine tumor, grade 1, with metastasis to the liver and all lobes of the liver. And there is a primary in the terminal ileum that's lighting up on the dotatate scan. Take the gallbladder out. The patient's not having any symptoms related to the primary tumor, no obstruction, no bleeding. Should the primary tumor come out?
So the answer is a little bit yes or no. Sorry. So the answer is a little bit yes or no. It's not should the tumor come out. It's when the tumor comes out. So the analogy I like to give all the time for neuroendocrine is that the runway is usually very, very long. Okay. How fast you're driving down the highway or the runway or whatever you want to call it, it depends, right? For the very first time, I've now lived in the West, and I've driven many miles across Kansas, and it's a long, long, long road. So the problem is not what to do. The challenge, and the reason I want people to see specialists, is when to do it, right? So if you're completely asymptomatic, and I never did a scan in you, and I never looked, and you didn't know you had cancer, sometimes the treatment can be worse. However, there can also be a ticking time bomb, right? So if the tumor's inside there and then all of a sudden you have a terrible obstruction and then the local surgeon takes you and doesn't do a very good job and things can go badly. So you are weighing kind of those things. So what I do is you have to ask a very, very detailed history because frequently people will have quote unquote IBS. Anyone in this room been diagnosed with IBS before? Right. When in fact it was actually the tumor that was causing those symptoms. And then we have a good reason to do it. The good thing I will say is that surgery, while it sounds scary and dangerous, especially for the medical oncologist, has become tremendously that's right. Thank you, doctor. Thank you, doctor. But it's become tremendously safer in the past 25 years. I mean, like tremendously. We can do some of these, pancreatectomies with 100 milliliters of blood loss. I mean, very, very little. Yeah, we've gotten very, very good at these operations. And so it's important to know, again, it's important to seek out the right expertise, right? You've heard me say that about 1 billion times. And then when you get that good expertise, to understand when it is appropriate to do. It doesn't have to be today. It doesn't have to be tomorrow, but it may be at some point.
Thank you, Dr. Liu. I think it's a topic of debate at almost every neuroendocrine conference, and there's we've had like pro and con debates on doing it, not doing it, but it's a individualized approach. We have a question in the audience.
Just to add to the debate, in terms of high grade.
Eric, pull your mask up. We can't hear you.
Yeah, in terms of high grade neuroendocrine carcinoma, maybe add to the debate there and the benefits of surgery or options.
Well, high grade's a little bit different, and high grade is still also in the eye of the beholder, right? So if it's between 30 and 40%, that's not nearly as high grade as 90% on the Ki-67. And it depends on how people are feeling. You can have a terrible tumor which is causing pain constantly. I can't cure you of the disease, but I can certainly make you feel better. And if you feel better and eating better, then maybe you can tolerate your chemo better. So all these things must be thought of together as a multifactorial treatment plan.
And just to add one comment, we don't fight. We love our surgeons. We work with our surgeons. The reason we always discuss those things is because there's lack of data. It's very difficult to do a randomized study where you say, flip a coin, you're having surgery, you're not having surgery, and then just direct people this way. It's just impossible. So we always rely on retrospective data. And you'll never know. And that's why we keep fighting. I kept fighting, with my brothers about who's taller when we realized it's because we're all short. So with surgery and medical treatment, what's better than the other? Unless we really have a clear-cut answer, we'll just keep fighting, not fighting, but bantering a little bit. That's why you have to individualize treatments. It's possible.
What Dr. Trikolino says is 100% true. It's easier to do kind of these clinical trials and research in medical oncology, and even that is very complicated. You cannot even imagine what it's like to do research in surgery because it is so difficult and so finite and so individualized. I mean, do I take this lymph node out? Do I get this farther out? I mean, everyone is so, I'll show you pictures this afternoon. No two tumors are the same. And so therefore, how I treat it and how I go after it is very technical. And so, you know, you can't do a clinical trial on technique. It's almost impossible to do. And so this is why it's so difficult. This is why you want someone who knows what they're doing, because the chances are they did it wrong in the past and they can do it better now.
A short comment about high grades, definitely NEC. I'm a strong proponent no surgery in metastatic disease unless it is in an exceptional situation, exceptional response, just one met left somewhere. But it is truly a systemic disease, very aggressive disease, and we can clear patients of the disease by surgery, but there will be micrometastatic disease, and the turnaround time is so fast that in NECs, the small cell and large cells in metastatic setting, very, very limited role.
Thank you all. That was fantastic to get your perspective on that. So we have time for one more question, and there's a lot more questions here, and some of them are quite specific to someone's scenario. So feel free, although we can't necessarily provide medical advice, we can help provide guidance. So if you submitted a question that is more specific to your situation, you know, feel free to grab one of us and, you know, chat, and we can bounce some ideas off each other. So for the last question for Dr. El-Khouli, so essentially the question is alpha particle therapy and the promise that it brings in terms of improving upon what we have already. What is your perspective on the prospects of alpha particle therapy, and where do you see that field going?
Well, it's promising. We are actually starting alpha particle trials in our institution, so this tells you that we think it has some promise in it. Like I said, it has it transfers more energy. It's bigger particle, but it doesn't move much. So we're hoping it's less toxicity. There's a lot of promise in that. The initial results are promising. We hope it's really gonna have good results. I can't tell much about it because this is a new research. We really have a lot of hope that this is going to give us good results. With Dr. Anthony, Dr. Anthony and I are starting a trial very, very soon. We just had a trial initiative visit last week, right? Dr. Anthony, you want to add something to this?
Chronology, the U.S. obviously lags the rest of the world. Unfortunately, it's just the way the world's created.
We are trying to change that.
Well, you know, we're building off of a trial that was done in India. They've already treated 64 patients in Delhi, so we're behind the Indians. So alpha appears to be useful in neuroendocrine tumors. It was very disappointing in prostate cancer. As we brought it on for prostate, I thought it was going to be revolutionary, and it was a dud. And then when we started developing it for neuroendocrine, I had that carryover effect from prostate. Oh my God, not that, you know. But it's different because neuroendocrine tumors are highly angiogenic, and the prostate cancers are not as angiogenic. So we are just bathing the tumor in alpha particles because of the high blood flow. And it appears to be very effective to date. We have still a lot to learn, but it is really exciting, the early data that we're seeing.
All right, terrific. Well, that concludes our question and answer session for this time. I want to thank our panelists, expert panelists here for taking questions and giving thoughtful answers, and to the audience for providing excellent questions. And like I said, if we didn't get to your question, you know, please pull us aside. We're happy to help.